Welcome to second part of medicine, that is part 2, and here we'll be discussing neurology. So we are starting our topic with amyotrophic lateral sclerosis, which is a very important part. Okay, yes. So the basic pathophysiology between ALS is it's a combined upper motor neuron plus lower motor neuron defect. So basically there is a degeneration of the corticospinal tract, okay, which originates from the higher centers. And also it involves a spinal cord level, it involves anterior horn cells. So it is combined, that's why we get mixed UMN and LMN signs. And sensory part is not affected, only motor part is affected, hence there is no sensory loss in ALS. Okay. Next, UMN loss, what are the features that we'll get? One is at the spinal cord level, corticospinal tract is involved, hence we'll get UMN sign, that is Babinski reflex will be positive. And second is there will be spasticity, UMN type of spasticity because of stiffness, that is involvement of upper motor neuron. In lower motor neuron sign, we'll get spinal cord involvement, anterior horn cell, that is why there will be atrophy, there will be wasting, at the same time there will be fasciculation. So both UMN plus LMN, there are very few diseases where we'll get UMN plus LMN, and one of them is this ALS. Okay, so sensory nerve test will be normal, that is a diagnostic clue for ALS. So there is one more type of ALS which is known as the bulbar type, where basically bulbar means what? Cranial nerve involvement. So brainstem involvement happens. Okay. So because of this there will be dysarthria and dysphagia. Dysarthria means difficulty in articulation of speech, and dysphagia means swallowing difficulty. Now what is the cause for this ALS? There is one genetic defect, that is SOD1 mutation. Okay, SOD1 mutation, which is familiar, that is one of the causes. Now what are the rare facts? There can be frontotemporal dementia, that is frontal lobe and temporal lobe associated dementia associated with ALS. Cognition is spared in early stages, which means a person may have normal thinking and all, but only the motor actions will be affected. And riluzole is one drug which actually prolongs survival. Riluzole. Okay, remember this. Now remember, in polio, which will be one of your differential diagnosis, there will be only LMN sign, there won't be any UMN sign, so don't confuse with polio. ALS is both UMN plus LMN. Okay, and there won't be any sensory loss, that is a clue. So UMN plus LMN lesion without sensory loss is nothing but ALS. Just you can blindly go to ALS. Okay, what is it is a mutation that is involved? SOD1 mutation. Drug prolonging life is actually which one? It is riluzole. Babinski positive, fasciculations and no sensory loss is ALS, and riluzole is used for treatment. Okay, so what is the management? See, this is a very devastating disease. There is no treatment for this. The only thing that is there is you give supportive care, and then you give non-invasive ventilation for respiratory failure. A very devastating disease, no survival rate. Okay, so very bad prognosis. So this is about ALS. Next, second we'll go to botulism. So in botulism, we should know what happens at neuromuscular junction. So this botulinum toxin is released at this botulinum toxin will actually block the release of acetylcholine. Okay, so this is acetylcholine. Botulinum toxin will inhibit the release of this acetylcholine, as a result of which we'll have descending flaccid paralysis. Very important. Remember, there are very important causes of ascending paralysis, but there are very few causes of descending paralysis. So descending paralysis means it will involve first cranial nerves, and then it will involve upper limbs, then it will involve lower limbs. Okay, this is in contrast to GBS and polio, where we'll have ascending paralysis. So from feet it will start, then it will go above. Here it is first cranial nerves, eyes will be involved, ophthalmoplegia will be involved, upper hands will be involved, then last it will be lower limbs. Okay, so it is descending paralysis, top down. Okay, what are the causes? So in your MCQ the clue will be canned foods. Okay, and spoiled rotten fish. Canned foods. Okay, canned foods will be the number one. Second is honey. Okay, honey will be given in your question. So it's a preformed toxin, that is toxin will already be there in the food. Initially features will be ptosis, then there will be dysphagia because of cranial nerve involvement, and then it will progress to descending paralysis. So in infant you will have this spores which will be present in honey, which will cause hypotonia, that is the infant will be unable to move its limbs, and then there will be constipation because after this spore injection. Okay, so we call this as floppy infant. So floppy infant will be one of the differential diagnoses is botulism when you are given a clue of honey. Okay, now there is one more mechanism, that is through anaerobic infection. Okay, they will produce spores, and this spores local toxin production will actually spread through slowly. Okay, so this also is a case of wound botulism. Okay, so there is foodborne botulism, there is infant botulism, and there is wound botulism. Now what is the clinical feature? Initially there will be fixed dilated pupils, that is because of involvement of cranial nerves. There won't be any fever, there won't be any sensory loss, but there will be flaccid paralysis, which is descending type. So on microscopy you will find Clostridium botulinum spores are seen. In microbiology we'll be seeing what is the how to diagnose all this. Okay, and then you do assay of toxin through stool or serum. Okay, now Your very common differential diagnosis will always be GBS, but there it will be ascending type of paralysis. That is, first lower limb will be involved, then trunk will be involved, then upper limb will be involved. Now, aminoglycosides actually worsen situation because of reasons that you should no need to know that right now. Okay, so you shouldn't give aminoglycoside in this case. So what is the drug of choice? Drug of choice is botulism antitoxin, okay, which is early administration will helpful in reversing the symptom. And second is supportive management. That is, still the action of botulism toxin is there, you will be giving respiratory support, that is through ventilatory support. Okay, I think I have discussed everything. We'll go to the next topic, that is CV and stroke, which is a very important topic. Okay, so basically what happens in stroke, there will be a thrombus, it will block the cerebrovascular supply, and as a result of which there is ischemia. This is ischemic stroke. What is hemorrhagic stroke? There will be hemorrhage, secondary to, most commonly secondary to hypertension, and there will be sudden onset neurological deficit. Okay, so neurological deficit can be anything from hemiplegia to paraplegia to quadriplegia, and it can also involve other things such as aphasia, depending on the territory of the brain involved. So out of total 100% of stroke, 80% are ischemic stroke, okay, which is most common. There are two types. One is thrombotic stroke and embolic. So embolic means somewhere else thrombosis formed that is carried to the brain. Most common is thrombosis only. Thrombotic stroke is more common than embolic stroke. This constitutes total 85%, and less 15% is through hemorrhagic stroke, out of which common are intracranial hemorrhage and subarachnoid hemorrhage. So important top points is, if the right side of the brain is involved in stroke, then there will be contralateral left-sided hemiplegia, and if dominant hemisphere is involved, that will also cause aphasia. So if left-sided stroke is involved, then there will be aphasia because dominant side is the left side. Now, MCA in fact is the most common territory. So MCA, blood supply, everything you should know, and we'll be revisiting this during anatomy. Now, there is a type of stroke known as lacunar, which occurs in hypertensive patients, where there will be micro infarcts in the basal ganglia that will cause pure motor type of stroke, because all these basal ganglia fibers, internal capsule, that will go to the this part only. Now, if there is subarachnoid hemorrhage because of secondary to berry aneurysm rupture, then always in the question there will be one thing, that is thunderclap headache, and there will be meningeal signs because of meningeal irritation. So sudden onset of thunderclap, very severe headache along with the signs of raised ICP you should mark your answer as subarachnoid hemorrhage. Usually occurs in young adults. Now, what is the radiological findings? See, first there will be ischemia, then necrosis will occur. Along with that, there will be cerebral edema, and then neurological deficit occurs. So initially on CT, there won't be any fine changes in ischemic stroke. That is because this ischemic changes won't be apparent on CT. So initially there will be subtle changes only, but in hemorrhagic stroke, there will be bright blood that is seen. Okay, blood will be seen as bright spot. Hence, initial CT, okay, NCCT is helped to differentiate whether it is ischemic or whether it is hemorrhagic. Okay, but for ischemic stroke, the diagnostic of choice is MRI, that is diffusion weighted images. It is very important. Diffusion weighted images in MRI is the most sensitive, and it will give early changes also. So if your question is like what is the investigation of choice, then always it is MRI with the diffusion weighted images. And if the question is how to differentiate between hemorrhagic stroke and ischemic stroke, for hemorrhagic stroke we'll use CT, which will help us differentiate. So this MRI, in that if you find there is some ischemic zone, then you have a window of 4.5 hours. Within 4.5 hours, you should be able to thrombolyze. So first investigation of choice is CT, that is non-contrast NCCT, because this will help you rule out hemorrhagic stroke, because you can't do thrombolysis if it is hemorrhagic stroke. And if you have less than 4.5 hour window, then you are eligible for TPA, that is thrombolysis. You can undergo thrombolysis, and hence there will be more survival rate. And then there will be aspirin, which is given within 24 hours if the patient is ineligible for TPA. That is, there are some contraindications for TPA, or if the patient has come after 4.5 hours. And then you should also do adequate BP control. You should keep BP less than 140/90. That is, after 72 hours, you shouldn't suddenly lower BP in stroke, because then that will compromise intracranial pressure, and then suddenly there will be reduced cerebral perfusion. So giving TPA before CT is very important. CT should be done before giving TPA, because you should rule out hemorrhagic stroke. And BP cutoff is 185/100. That is because if you keep more than 185/100, then there can be fatal bleed when you give thrombolysis. Okay, when you do thrombolysis. So which is the most common type of stroke? It is ischemic stroke. MCA territory, if it is involved on the dominant hemisphere, you will have aphasia. Along with that, you will have contralateral hemiplegia. Thrombolysis window, remember, it is 4.5 hours. Normal CT with the signs less than 6 hours indicate ischemic stroke, because after 6 hours only you can find ischemic signs on normal CT. And Sudden worst headache should point you towards subarachnoid hemorrhage and lacunar stroke along with hypertension that is seen in hypertensive people, that is known as lacunar stroke. Okay, so fast is for a stroke. Okay, so what is fast? Fast means face drooping, then arm weakness, speech difficulty, and time to act. Okay, so that is how it is. That is the meaning of this. Okay. Okay, fine. So I think I have explained everything which comes under stroke. Remember, stroke is a very important question. Today itself, go and solve Q bank related to stroke. Okay. Next, we have important topic from CNS, that is cluster headache. So basically, what happens is, okay, so hypothalamus actually is related to this circadian rhythm, and this hypothalamus, or posterior hypothalamus especially, is related to this cluster headache. Okay, so that's why there is always a diurnal variation in this. There is a trigger, and along with that, autonomic features is linked to this hypothalamus. So in cluster headache, there will be severe unilateral. Remember, it is not bilateral. It is unilateral orbital pain which occurs in clusters. Okay, it is associated with autonomic features, that is lacrimation, rhinorrhea, and ptosis. So these are the autonomic features that are involved. Okay, so what is the characteristic of this headache? This is a very important MCQ differentiator. Headache will last for very short duration, that is between 15 to 180 minutes, and it will be daily. Remember, it will be daily headache lasting for 15 to 120 minutes. It will be just like alarm clock. That's why it is related to circadian rhythm of hypothalamus, and it is recurring. It recurs every day. Okay, and it is associated with autonomic features, and there will be some triggers like alcohol, sleep. If there is less sleep, then that will be a trigger, and it is more common in males, not in females. Tension type of headache is more common in females, but here it is more common in males. So imaging is done not because you want to rule out pituitary causes, because pituitary causes can also result in similar symptoms. So circadian rhythm is related to hypothalamic activation. It can coexist with other restlessness symptoms. Also, you can confuse this with migraine, because migraine is also unilateral, it is also throbbing type, but this occurs on same duration, like daily it will be there for same duration, associated with autonomic symptoms. Okay, next, but migraine headache will be for longer duration. It will be for longer than 1.5 hours. It can last up to 24 hours. Okay, so beta blocker has no role in cluster headache. Okay, so what is the acute management of cluster headache? It is high flow oxygen. Yes, this is something very different. Okay, why it is, we'll not go into that. So high flow oxygen for 10 to 15 liters per minute at that rate is the best acute treatment, and then we have subcutaneous sumatriptan, which can also be used. Prophylaxis is using verapamil. Okay, verapamil also we'll use in migraine prophylaxis also, but here also prophylaxis mainly is based on verapamil. So which is the best acute treatment for cluster headache? It is not any anti-headache, not NSAIDs or anything. It is 100% oxygen along with subcutaneous sumatriptan. Prophylaxis we use verapamil, which is a calcium channel blocker. It is male predominant. It lasts for 50 to 180 minutes, and then trigger is alcohol. Okay, so this is how it is. C clocked. Clocked means it always occurs at same duration, associated with lacrimation. It is unilateral type of headache, severe. There will be associated trigger, unilateral behind the eye, and it occurs. It is associated with restlessness. Okay, now you won't forget oxygen therapy for cluster headache. Next, we have cranial nerves. Now, cranial nerves is repeatedly asked from anatomy also. It is asked from physiology. It is asked in medicine. It is asked in pediatrics. So, wide variety of applications for cranial nerves, and hence we'll go into detail with cranial nerves. So, going to cranial nerves, we'll just touch most important parts only. We won't go into basics and all. In cranial nerve, one most important thing is this, which fracture, frontal bone basal fracture. Frontal basal fracture actually causes cranial nerve 1 injury. In cranial nerve 2, optic nerve is the afferent for pupillary pathway. Efferent is cranial nerve 3, that is oculomotor nerve. Oculomotor nerve will go again in depth in ophthalmology, where we'll be discussing ptosis and dilated pupil. All this will be discussing again. Okay. Cranial nerve 4, that is trochlear nerve, we know that it controls superior oblique. Okay, so superior oblique is under the control of trochlear nerve, and this is important because in your question in your MCQ, patient will come with the vertical diplopia and head tilt. The moment you hear the head tilt, directly go for trochlear nerve, that is 4th nerve. Okay, and in anatomy, one question is asked, which cranial nerve has the longest intracranial course, that is cranial nerve 4. Okay. Cranial nerve 5, that is trigeminal, there is no much of questions are asked, except that the corneal reflex, efferent pathway is mediated by trigeminal nerve. Efferent is by 7th nerve, that is facial nerve. And jaw deviation, again, I think this you know already. Abducent nerve, very easy. I think I don't have to tell you, except that in raised ICP, this causes a false localizing sign. Okay, false localizing sign. That is, there will be paralysis of the 6th cranial nerve, causing loss of lateral deviation. So the eye will go into medial deviation. Okay, so this is known as esotropia, and this is a false localizing sign in increased intracranial pressure. Okay. Now, 7th cranial nerve is very important. We'll be going through this in ENT, so we won't discuss much here. 8th cranial nerve also we'll see in ENT. 9th is important because loss of gag reflex. Okay, this occurs in 2 conditions. One is cranial nerve 9, that is bulbar palsy, and second is pseudobulbar palsy. So you should know what is bulbar palsy palsy and what is pseudobulbar palsy. Bulbar palsy means actually the cranial nerve origin, that is the cranial nerve nuclei is affected. Okay, so it will cause LMN type of paralysis. Whereas in pseudobulbar palsy means nerves are proper, cranial nerves are proper, but the higher control, that is the corticospinal tract, that is from the cortex till this cranial nerve nuclei, that pathway is affected, and hence you will feel that there is bulbar palsy, but it is not actual bulbar palsy. It is because of the involvement of UMN lesion. Okay, that is corticospinal tracts. Okay, corticobulbar tracts. Okay, corticobulbar tracts. That is in the CNS part. Okay, that is above. Okay, above the level of the cranial nerves nuclei. Okay. So this is important in case of stroke and all, where in stroke most commonly that is when this internal capsulant is involved, it will cause pseudobulbar palsy. That is actual cranial nerve nuclei is not involved. But in case of GBS and all, where LMN is involved, that is cranial nerve nuclei are involved, there will find bulbar palsy. So then we have vagus nerve. These are the symptoms, that is hoarseness, uvular deviation and dysphagia. One important thing you should note is here, vagus nerve and facial nerve both is 10 plus 7, that is equal to 17, as well fifth nerve, trigeminal, and 12, these also 5 plus 12 is equal to 17. Now I am telling that you know that 10 plus 7 means 10th nerve, that is vagus, and 7th nerve. You know that what happens in facial palsy? In facial palsy, the deviation of the mouth is opposite to the side of the lesion. Okay, so that's why uvula also in 10th cranial nerve palsy, I told you in 10th nerve, that is vagus nerve palsy, uvula gets deviated. So in both the case, here face deviation is towards the opposite side. Similarly, uvula deviation also in case of 10th cranial nerve palsy is towards the opposite side. Whereas for trigeminal and hypoglossal, in trigeminal nerve injury and hypoglossal nerve injury, in hypoglossal nerve injury, tongue deviation is towards the same side. Here also jaw deviation is towards the same side. So same side occurs in 5th and 12th. Opposite side deviation occurs in 10th cranial nerve and 7th cranial nerve. This is the mnemonic. Now for 11th cranial nerve, that is accessory cranial nerve, accessory spinal nerve, you will have head turn and shoulder shrugging. So inability to turn the head and shrug the shoulder is the classical of 11th. And 12th I just told you, tongue deviation towards the same side of the lesion. Okay. Now some important things is these we have already discussed. Now where do you go wrong? That is, one is you will confuse nucleus versus nerve lesion. Nucleus means the ganglion which is there. Okay, the origin point of that lower motor neuron. Okay, that is known as cranial nerve nuclei. And what is nerve? Cranial nerve is after the origin of the nuclei, the course of the nerve, that is known as cranial nerve. Okay, so these two are different things. Now Bell's palsy is not a stroke because Bell's palsy is a lower motor neuron type of lesion. It is not upper motor neuron. Now cranial nerve with longest path is, yes, very good, 4th cranial nerve. Corneal reflex efferent pathway is V1, that is trigeminal nerve. Bell's palsy nerve is 7th nerve, you know this. LMN facial palsy, whole side of the face is weakened. What is the meaning of this? See, if it is 7th cranial nerve palsy, that is Bell's palsy, okay. If it is lower motor neuron, then we call it as Bell's palsy. Bell's palsy is nothing but 7th cranial nerve, lower motor neuron. Now what is this I'm telling? Lower motor neuron, upper motor neuron. So basically this is the brain, okay. And from here we have corticobulbar fibers. This is the cortex part, and this is the brain stem, okay. From brain stem, from medulla, we have origination of this 7th cranial nerve. So whatever is there above this, no, these tracts, these are basically UMN, and this pass through internal capsule and all, okay, through thalamus, internal capsule, it will descend. Now this is nothing but UMN, and this is nothing but LMN. So whenever there is UMN lesion in the face, okay, you know that 7th cranial nerve only opposite side of the face is affected. So let's say this is right side. So here left side only upper half is spared, lower half is spared, okay, upper half is not spared, only lower half in case of UMN. And in case of LMN, okay, LMN facial palsy, that is after the origination of the cranial nerve nuclei, that is 7th nerve. If this is involved, this is called as Bell's palsy. Here, whole half of the face is involved on the opposite side. If this is right side, then left side, whole half of the face is involved. Now, why is this? Because upper side of the face has bilateral innervation from both right side and left side, but lower side has only single innervation. Okay, so that's why in lower part we have involvement of whole half of the face, but in only UMN type of facial nerve lesion, that is if the lesion is in the form of stroke of upper motor neuron lesion, if there is some vascular problem in the upper motor neuron part, and that 7th cranial nerve is also affected in that case because of upper motor neuron lesion, then we will have only upper half of the face is involved, lower half is spared. Okay, sorry, lower part is involved, upper half is spared. Okay, so that is how we differentiate. Next is yes, UMN, lower face is only involved. Okay, next jaw jerk is if it is a UMN lesion, then jaw jerk will be exaggerated. That is in case of strokes and all, jaw jerk will be exaggerated, but in LMN lesion, jaw jerk won't be exaggerated. Okay, yes. So next we'll see what are the functions. Okay, so I think these you can go through. There is nothing. Some mnemonic as LR6 and SO4 means lateral rectus is supplied by 6th nerve, superior oblique is supplied by the 4th nerve. Okay, and rule of 4. What is rule of 4? First two cranial nerve, that is 1 and 2 has separate courses. You know that. 3 and 4 is for midbrain. 5, 6, 7, 8 is in the pons origin, and medulla we have 9 to 12. Okay. Yes, I think I have explained everything, and yes, now we can go to the next topic. So next we have dementia. So basically we have different types of dementia. Dementia is nothing but cognitive decline with preserved consciousness. Consciousness is not affected, only there is cognitive decline. So your question will have, that is MCQ will have completion of task. There will be problem like cooking, the patient can't do finances, can't remember things. So it interferes with daily function. So which are the different types of dementia we know? We have Alzheimer's, vascular dementia, Lewy body dementia, frontotemporal and reversible. And this single table, remember, will actually help you differentiate all types of dementia, and these are MCQ recall points only. Okay. So in Alzheimer's dementia, remember, always memory is affected first, and on microscope you will find amyloid, beta plaque and tau tangles. Okay, so this we covered in pathology also. So if you haven't watched pathology endgame, please go and watch. And there will be hippocampal atrophy. That's why memory is affected first, and this is the most common Alzheimer's dementia. Second is vascular, where you'll actually find stepwise decline, and there will be multiple infarcts. So remember, multiple infarcts, always think of vascular. Why? Because of this infarcts, there is actually because of some vascular problem, there is infarcts, and because of infarcts, we have dementia. Okay. Third is Lewy body, where important thing is this hallucinations. Okay, visual hallucination, and this alpha synuclein. Okay, so this alpha, again, this we had covered in pathology. Please go and watch it. Fourth is frontotemporal, where there will be personality change early. Now remember, frontal lobe is the seat of personality. So whenever there is alteration in the frontal lobe, there will be personality changes, and here you'll find something known as PIC bodies, and here it will be altogether behavior issue. And last we have reversible causes of dementia, such as in hypothyroidism, in B12 deficiency. So you'll do these tests, and these are actually reversible causes. So mainly you have 4 causes, out of which most important is Alzheimer's, then you have Lewy body, then you have vascular, then you have frontotemporal. So there shouldn't be any confusion regarding this. Okay. Next, slow wave, see some important things that are required. Hippocampal atrophy, that is actually an autosomal dominant phenotype. Second is MMSA. What is MMSA? Mini mental score examination. That will be less than 24 in case of dementia. Then we say that there is severe impairment. What are modifiable risk factors? Hypertension and diabetes, because both causes vascular pathologies, and these vascular pathologies actually can lead to dementia. Next, what is the treatment? Cholinesterase inhibitors. Okay, cholinesterase inhibitors, that is donepezil we use for Alzheimer's disease. We use donepezil. Okay. Sorry, one correction I want to tell, that is hippocampal atrophy. This is AD is not autosomal dominant phenotype. It is nothing but Alzheimer's disease. Okay, so Alzheimer's dementia will find hippocampal atrophy. And the slow waves. So when you take EEG, if you find slow waves, okay, don't think it as dementia. Okay, this means that it is some reversible causes. In a patient with dementia, if you are taking EEG, then it could be some reversible causes because of metabolic reasons like hypothyroidism, okay, or some other electrolyte abnormalities. So the slow waves are not typical of dementia. It goes against dementia. Yes. So very important, delirium is acute. Okay, dementia is chronic. Okay, delirium is acute, dementia is a slow progress, and then there are some reversible causes which you should know. So which is the commonest type of dementia? Alzheimer's. Very good. Stepwise decline is seen in which? Vascular. Personality affected is in frontotemporal. Visual hallucination in Lewy body. Personality change in FTD, that is frontotemporal, and memory loss and beta amyloid plaques will be seen in Alzheimer's. So this single table will have everything that is required for you to solve MCQs. Okay, so there shouldn't be any confusion. Next, we'll go to Guillain-Barré syndrome. Okay, so what is the most common cause? It is infection only. Infection leading to immune reactions and then causing myelin damage. And then we have very important classic, that is ascending symmetric weakness. Now I'll tell you, there are some causes of descending paralysis which you should know. One is botulism, okay, and second is diphtheria. These two are descending causes. One more is tick paralysis. Okay, tick paralysis is also descending. Now these are descending. Now which are ascending? You have polio, you have GBS. These two are main important, polio and GBS. Now polio is asymmetric and GBS is symmetric. Now what is the meaning of symmetric? Polio will come in one limb and then will go to another hand. Okay, that is upper limb, lower limb. It won't be symmetric involvement. But in GBS, both the lower limbs will be symmetrically involved. That is, both power loss will be equal in both the sides. Okay. And along with this, there will be one more important feature, that is areflexia. Areflexia. Now, what is the importance of this areflexia? Because anytime you have a upper motor neuron lesion, you won't have areflexia. You will have hyperreflexia. Your reflexes will be exaggerated. Like for example, a stroke. But in case of LMN, like GBS, what will happen is your reflexes will be decreased. So that is known as areflexia. Now, which is the most common type in India? In most common type is GBS is EIDP. That is acute inflammatory demyelinating polyneuropathy. Acute inflammatory demyelinating polyneuropathy. Here what happens is, this myelin is there, no? So demyelination occurs here, okay? Demyelination. Now there is one more form that is known as axonal variant, that is acute motor acute motor neuropathy and acute motor axonal neuropathy and acute motor sensory axonal neuropathy. Okay, so these are basically axonal form. So here the axons are involved. See here axons. Okay, here what is involved? Here myelin is involved. Okay, so most common is EIDP in case of India. In overall in the world, you'll find Aman and Amsan variants are more common. There are other variants also. That is Miller-Fisher variant, which is asked for your exam. So in EIDP, what happens? Antibodies are against this myelin sheath. Okay, against myelin. So here you'll find albuminocytological dissociation. What is the meaning of albuminocytological dissociation? That means that proteins are very much increased in CSF, but cell count is normal. Cell count is normal, protein is increased. In Aman-Amson variant, these are little bit severe forms where there is rapid progression. Okay. In Miller-Fisher variant, you have ophthalmoplegia. That means you have paralysis of your extraocular muscles, ataxia. Okay, and along with this, you have areflexia. Okay, areflexia. So this is the triad of Miller-Fisher variant. Now, Miller-Fisher variant is involved, associated with certain infections such as varicella. Okay, post-varicella and some viral infections. You can actually get Miller-Fisher variant. Now, here in Miller-Fisher variant, one important antibody which you should remember is anti-GQ1B. Rest all you don't want to remember. Just remember this much. Okay. Now, absent reflexes, areflexia is the hallmark of GBS. And next, autonomic features can also occur because of involvement of autonomic nerves, that is BP fluctuation and arrhythmia. When I was posted in PICU, pediatric ICUs, we had a lot of cases of GBS, and we used to see a lot of this BP fluctuations, tachycardia, arrhythmias in patients with GBS. So it is very common. Okay. Next. What is the most fatal complication? It is respiratory failure. That is, it will slowly ascend from the legs, it will ascend to the chest, and slowly it will involve diaphragm. And because of involvement of diaphragm, we'll have respiratory failure. There is no benefit in giving steroids. That's why what is the treatment of choice? Treatment of choice is IVIG. Okay, always IVIG is the treatment of choice. Second choice is plasmapheresis. We don't give steroids. Okay, it is either IVIG or plasmapheresis. Then early ventilation so that patient doesn't go into respiratory failure. Next, CSF pattern, increased protein and normal cell. This is known as albuminocytological dissociation. Most common type is EIDP. Treatment is IVIG and plasmapheresis. If it is ascending and areflexia, think of GBS. Anti-GQ1B antibodies, think of Miller-Fisher. Is steroids helpful? No, steroids have no role in GBS. Okay, because steroids have role in one more condition, that is transverse myelitis. Transverse myelitis, actually steroids are very helpful. Next, we'll go to Huntington's disease. Next topic that we'll go into is Huntington's disease. So again, a repeatedly asked question, especially from the preclinical, that is genetics part. So this is first is it is autosomal dominant. When it is autosomal dominant, first thing that should come to your mind is Huntington's. Okay, it is not recessive, not anything else. And there is one particular sequence here that is CAG repeat. Okay, so CAG repeat actually occurs this trinucleotide repeat. Now, Huntington's gene is gene number 4. Okay, this is one thing that you need to remember. And what happens is there is chorea along with cognitive decline. Okay, now what are the extra things that you need to know? Chromosome 4, I have already told. It affects onset is in the young adults, that is around after 30 years, with progressive chorea. And then there is autosomal dominant. Now, what is this anticipation? Anticipation means as the successive generations come, symptoms actually increases as generations succeed. So in first generation, symptoms would have been less. It would have been late onset. But when it comes to third generation, symptoms will be early onset and it will be more severe. So what happens is basically there is acetylcholinergic receptor neurons where actually acetylcholine is released and it causes increased movements. Okay, and then there is inhibitor, that is GABA. Here what happens is there is increased dopamine also. Okay, dopamine actually facilitates action. So in Huntington's, what happens? There is loss in this GABAergic neurons, as a result of which there is no inhibition, and as a result of which they will have this symptoms such as chorea and involuntary movements. Okay. Next is what is MRI finding? Classic is caudate. So this is the caudate. Okay, here this caudate atrophy, as a result of which this ventricle appears the shape of a car. Okay, boxcar appearance of ventricles. Confirmatory test is via genetic testing only. You see for CAG repeats. So yeah. So what is the treatment for this? Treatment is basically tetrabenazine. Tetrabenazine is an anticholinergic. Okay. Second is supportive care, and third is there is a juvenile form of Huntington's, which is actually variant in which psychiatric symptoms come first, and then rest of the symptoms come. So remember, it is not autosomal recessive, and there is one phenomenon called as anticipation, which I have discussed. So to summarize, which is a gene locus? Yes, very good. It is chromosome 4. Which neurotransmitter is decreased? GABA is decreased. Very good. Inheritance pattern is autosomal dominance, dominant pattern along with anticipation, which repeats, CAG repeats, and then there is chorea. And then and also one thing that this CAG repeats actually detect how much severe the chorea is. Okay. Next, caudate atrophy occurs in MRI, which is actually confirmatory. Moving on to next topic, that is stroke classification. Again, once more, we'll just brush through this. So different types of stroke are, one is thrombotic stroke, which occurs because of atherosclerosis due to thrombosis, and here middle cerebral artery involvement is more common than internal carotid artery. Next is embolic stroke, mainly cardiac source. Okay, and it has sudden maximal onset deficit at once. So basically what happens in thrombotic is patient wakes up and then slowly slowly he has progressive weakness. But in embolic, the maximum weakness is at the beginning, and this is a clinical MCQ indicator that you should differentiate between embolic and thrombotic. So embolic is sudden onset, and thrombotic is gradual progressive onset. Third is lacunar stroke, I told already, which occurs with hypertension. Then watershed. What is watershed area in brain? Watershed area means there are some areas which are supplied by one artery only. Like this much is supplied by middle cerebral artery. This is by posterior cerebral circulation and anterior cerebral. So these are like hardcore territories, okay, in which there is no like interchange, no collateral circulation. That is known as watershed area. And what is TIA? TIA means basically it's a stroke but without any infarct. So basically it's a warning before stroke. Basically there is no infarction, but there are symptoms because of a decreased blood supply. Okay. So which is the most sensitive indicator? Yes, it is diffusion weighted imaging, okay, in MRI. So if it is less than 4.5 hours since onset, then you go for thrombolysis, and if it is less than 24 hours, you can go for aspirin, okay. So important thing is you should differentiate hemorrhagic from ischemic stroke, and the best thing to do is do a NCCT head, which will differentiate hemorrhagic from ischemic, okay. I think all these things we have answered, and we'll go to the next question. Yes, coming to infection part of CNS, that is meningitis. Now meningitis is the inflammation of this layer, that is meningeal layer of the brain, okay. So inflammation of the brain parenchyma is known as encephalitis. So this is encephalitis. The outer layer is known as meningitis. Okay. So what are the things that you get here? Your MCQ will have fever along with neck rigidity, altered sensorium, neck rigidity, and fever. Okay. So these are the causes. Now your questions will be mainly whether it is bacterial, viral, whether it is TB, or whether it is fungal. So how to differentiate? You don't have to go through all this. This is the classic table that is given. So you should basically focus on few indicators only. First is if it is turbid, clearly it is bacterial based on appearance, and if it is cobweb, it is TB. Remember this. If turbid is given, directly mark bacterial. If cobweb is given, directly mark TB. Second, if polymorphonuclear, that is neutrophils are increased, directly mark bacterial. There is no other situation where neutrophils will increase. Neutrophils are very high, mark as bacterial. Very high means more than like even one neutrophil is also considered as significant in meningitis. Okay. In rest all cases, lymphocyte only will increase. Third case, what is TB? TB basically is a bacteria which forms this cobweb and all. So cobweb means what? It is basically proteinaceous material. So if protein is increased very much, then mark TB. So usually protein will be in the range 100 to 200. Normally it is less than 40, but it will be more than 100 up to 500, and also you can directly mark TB. Okay. Next is glucose. Glucose will decrease in case of bacterial. So if glucose is decreased less than 20, okay. Usually we say what is the normal range of glucose? Normal range of glucose is more than 2/3 of the random blood sugar done at that point. Means when you are doing lumbar puncture, you should collect the CSF. At the same time, you should do capillary blood glucose also. If it is more than 66% of capillary blood glucose, that is random blood sugar, then it is normal. If it is less, then we call hypoglycorrhea, okay. And this hypoglycorrhea, that is decreased sugar in CSF, occurs in bacterial. That is typical of bacterial, okay. And last is classical triad. All this bacterial meningitis triad, which is described, it is more typical for bacterial meningitis as compared to rest of them. And in fungal meningitis, you will get one important clue, that is India Inc was done. That was mainly for Cryptosporidium, and there you got positive for Cryptosporidium, okay. So this is how you differentiate. These are the same points which I mentioned, okay. So one more important thing is in all cases CSF opening pressure is increased except viral. Okay, in viral CSF opening pressure is not increased. Next, what is the empirical treatment? We assume all if we assume it is bacterial, then we give a third generation cephalosporin, which is nothing but ceftriaxone, and along with that we give vancomycin. So ceftriaxone plus vancomycin is the drug of choice. Then if it is TB, then we'll give dexamethasone. If it is pneumococcal meningitis, then also we'll give dexamethasone. But if one best option is in case of TB meningitis, we'll give dexamethasone. Okay. And yes, one important thing to rule out before doing lumbar puncture is you have to do CT. Always remember, do CT before doing lumbar puncture, because if you have CNS symptoms and if the patient has raised ICP features, then if you do LP, there will be sudden decrease in ICP and brainstem can herniate, causing immediate death. Okay, so that's why in your sentences it will be all are true regarding lumbar puncture except. So in that except, one option will be do LP straightforward. So don't do LP straightforward. First rule out increased raised ICP. Okay. Second is you shouldn't delay steroids in case of TB, and even in case of pneumococcal meningitis also you can start steroids right away. Next, so if the CSF is turbid along with decreased glucose, remember it is bacterial. Cobweb is there, then it is TB. India Inc is there, then it is cryptococcal. If decreased glucose along with increased PMN, that is neutrophils, then it is bacterial. Lymphocytes are there along with decreased glucose, remember TB, and normal glucose, remember it is viral. Okay, so basically in viral you will have just symptoms and you have marginal increase in lymphocytes. Other than that, everything will be almost normal only in viral. Okay, yes. So we'll go to the next topic, that is migraine. Next is migraine. Okay, so you should know there are some triggers for migraine, and this will be in your MCQ. One is hormones, second is stress, and third is insomnia. So once these triggers are activated, then there will be activation of this trigeminal, which means the blood vessels which are related to trigeminal nerve. Okay, basically it's present in the brain stem and along the nerve roots along the nerve root of trigeminal nerve. That will cause vasodilation by this neural mechanism, which will release CGRP. Now, CGRP is a very important molecule in case of migraine. So, CGRP is nothing but calcitonin gene-related peptide, okay? Gene-related peptide. Now, because of which there will be vasodilation, and you know, whenever there is vasodilation in CNS, actually there is increased blood flow, and then you get this throbbing type of headache, okay? So, it is recurrent unilateral headache, which is associated with or without aura. Aura is not a mandatory, okay? So, you have two types, with the aura and without aura, okay? So, without aura is the commonest type, where your headache duration, see, when we were seeing cluster headache, it was between 1 hour to 180 minutes. That is 1 hour, that is over 1 hour to 3 hours, okay? But when you see this migraine, it is basically 4 to 72 hours. So it can last up to 3 days. Important is the association, that is photophobia and nausea immediately after the onset of headache. This is the most classical sign. If it is with aura, then you have something known as cortical spreading depression. Okay, just remember this term. You don't have to go in depth to what it is. And associated with that are visual hallucination, that is known as visual scotomas. Basically, you will see these zigzag lines in the visual field. Okay, so these are the basic aura. There are other aura also. There are auditory auras, there are tactile auras and all. But most common is this visual aura. Okay, so this along with these symptoms constitutes migraine. So basically, it is unilateral recurrent headache. Okay, which lasts for 4 to 72 hours. Now, what is the treatment for migraine? First line is always triptans. You have sumatriptan, rizatriptan, and other triptans, and then you have NSAIDs. Okay, so these are the like first line, that is for abortive therapy. And for daily prophylaxis preventive therapy, you have propranolol and topiramate, and there are few others also. Valproate is also there. Okay, you have some calcium channel blockers which are used. Okay, now some important things that you should remember is, one is there is something known as basilar migraine, where your aura symptoms are related to brainstem. So when I was in residency, I was posted in pediatric neurology, and we had a patient who had this recurrent episodes of headache associated with features like vertigo. She had vertigo, tinnitus, and then attacks also, which was there for a brief amount of time, okay, brief period of time. And we were not able to diagnose, but our pediatric neurologist, he assumed that it could be. Then we had diagnosed it as a case of basilar migraine, and she actually improved. Okay, so this basilar migraine is also an entity which you should know about. One more is menstrual migraine. I told you that there is hormonal stress in migraine. So whenever there is estrogen drop, especially during menstrual cycle, that time women get migraine. So this is a type of migraine only which you should know about, which rarely can be asked in INSAT. So very important is that there is something known as hemiplegic migraine. Hemiplegic migraine means that this migraine is associated with the hemiparesis, which means you will think it is stroke. You will think it is recurrent stroke. It will present as recurrent stroke. Like one side of the body, there is hemiplegia completely. It starts and then it subsides after like 2 to 3 days. It subsides. Patient will improve after 5 to 6 days. There is no residual damage and all. No residual neurological deficits. So that is known as hemiplegic migraine. And this hemiplegic migraine, it usually runs in families. And here we don't give triptans. Okay. So triptans, even though we give a normal migraine, but in hemiplegic migraine, we don't give triptan. Okay. One more thing is this aura associated with migraine to last for less than 1 hour. Like it will come and then it will go and then it will follow by photophobia, nausea and all. Okay. But if it lasts for more than 1 hour, you should definitely rule out TIA. Okay, that is transient ischemic attack, which we saw under stroke. So what is the other treatment aspect that you should know about? One is lifestyle modification, avoid stress, avoid triggers, and second is avoid tyramine food, because these are also associated with migraine. Okay, so what will be your MCQ word? It will be pulsating, unilateral, okay, recurrent headache associated with nausea, and it will be disabling type of headache. You won't be able to do normal activities lasting for 4 to 72 hours. That is the MCQ line that you should be searching for. So commonest type of headache, that is migraine, is without aura. Abortive type of, what is the abortive treatment? That is first line treatment is triptans. Then preventive therapy, you have prophylactic agents. There are many more. Visual aura with throbbing is associated with migraine. Cluster headache, there will be lacrimation. Okay, so in migraine you won't get lacrimation. And menstrual trigger also occurs in migraine. Okay, so these are the basic things that you need to know to answer your questions. We'll go to the next topic. Next topic is epilepsy. Again, from epilepsy, many questions are being asked from medicine, from patho, and even from pediatrics. Okay, so what is epilepsy? Basically, there is an hyper excitable focus. You know that neurons are all wires, and in between these wirings there will be some focus which is producing some impulse. Okay, so this hyper excitable focus causing a synchronous discharge which travels along the brain, causing seizure. Okay, and then there will be some time after which patient will recover, that is known as post-ictal recovery. So which are the type of seizures? Recently IELTS, okay, sorry, ILAE, International League Against Epilepsy, sorry, okay, ILAE, okay. So it has released a new classification system for seizures, but these are the basic things that you need to remember. One is, earlier we used to have term partial seizures, okay, that is partial seizures and generalized seizures. Now we have replaced this. Partial seizures are known as focal seizures, okay, and and then we have generalized seizures. Okay, so now we call it as GTCS, generalized tonic-clonic seizures, and earlier we used to call it as simple partial seizures. Now we call it as focal seizures. Okay, focal seizures with awareness and with impaired awareness. Okay, this is a new term. Earlier term was simple partial seizure. Simple, I'll just write it here. Simple partial seizure and complex partial seizure. Simple partial seizure is now known as focal seizures, okay, with awareness, with intact awareness, okay. It means your awareness is normal, you'll just have movements, that is seizures. Complex partial seizures is now known as focal seizures with impaired awareness, okay, with impaired awareness. So these are basically seizures which are focal, but you won't be aware, that is consciousness is affected during this complex partial seizure. Then we have generalized seizures, okay. In generalized seizures you have generalized tonic seizures, generalized clonic seizures, then you have myoclonic seizures, okay, then you have absence seizures, okay, then you have atonic seizures. All this come under this, and there are many other, one more category known as autonomic symptoms involved, okay. So that is a separate category. So you need to basically remember that this focal seizures with preserved awareness, that is known as simple partial seizures. So basically there is a small spike somewhere, okay, and there is no loss of consciousness, and there is only motor or sensory symptom, that's it, okay. So it can be sensory symptom also, okay, not only motor symptoms. Focal with impaired is basically complex partial seizures, which we earlier used to call as, and here there are temporal lobe is mainly associated, and there are temporal spikes, and here you will see something as automatism. So automatisms are some random lip smacking movement like this. Random lip smacking movements, okay, so these are or blinking type of movements, so these are automatisms, and there will be post-ictal confusion, which means after seizure patient won't be knowing what has happened, okay. Next is generalized tonic-clonic seizure, which was earlier known as grand mal epilepsy. So here we have those typical the seizure which convulsions, okay, that is first there will be loss of consciousness, then there will be tonic phase, and then there will be clonic phase, okay. So this is the GTCS type. Then fourth is absence seizures, where there will be like brief blank staring look, okay, associated with 3 Hz spike. This is common in like children, okay. So this is absence seizure, and then we have myoclonic, where basically there will be sudden jerky movements, okay. So this is known as myoclonic seizures. So just remember this much, okay. So when it comes to drug of choice, I think we have discussed this in pharmacology also, neuropharmacology. So again we'll discuss. For GTCS we have valproate, because valproate acts on all mechanisms, okay. It has sodium channel blockade, it has calcium channel blockade also, and it has GABA inhibitor action also. So valproate is one which has all 3 types of action. Next is carbamazepine, which is used for complex partial seizures. Okay, so if it is focal seizure, any type of focal seizure, our first drug of choice becomes carbamazepine. And for absence seizures, we have ethosuximide, but in India, ethosuximide isn't widely available. That's why we go to valproate itself. Okay. Now, for status epilepticus, first choice is always benzodiazepine. It can be either midazolam or it can be lorazepam. Okay, so these are the first line of choice, or it can be diazepam. Nowadays, we prefer midazolam and lorazepam. Diazepam is less preferred. And then we have this sequence. That is, first we'll go to phenytoin, then we'll go to valproate, phenytoin, then phosphenotoin, then valproate, then we'll go to lamotrigine, okay. Then there's a big status epilepticus protocol only, okay. There is a separate entity known as West syndrome, okay. So basically there is global developmental delay, that is GDD. Along with that, there is infantile spasm and hypsarrhythmia. Hypsarrhythmia is an EEG finding, okay. So these 3 constitute something known as West syndrome, and here we use something known as vigabatrin, okay. Vigabatrin is the antiepileptic of choice. However, in majority of the cases, we use ACTH also, because this is known to suppress with the ACTH hormone. That's why ACTH or vigabatrin, or we'll use okay, I'm telling or we use high dose methylprednisolone also, okay. High dose corticosteroids also we'll use. Sorry, not methylprednisolone. We use high dose corticosteroids, okay. Prednisolone, okay. We use prednisolone. So next, ketogenic diet has some role in refractory status epilepticus, okay. So these are basically treatment for those seizures which don't subside. So basically these are refractory epilepsy treatment, okay. Now, 3 Hz spike is seen in what? Absence seizures, okay. Next, drug of choice for GTCS is valproate, I already discussed, and status epilepticus which lasts for more than 5 minutes will give benzodiazepine. Now, brief blank stare is absence seizure. Morning jerks along with the sleep deprivation trigger is juvenile myoclonic epilepsy, and more than 5 minutes we call it as status, okay. Next. There are some, syncope is different, seizure is different. In seizure, there is loss of consciousness, there is impaired consciousness, along with that there are like jerky movements and all, okay. So that is epilepsy, that is seizure. And then epilepsy is basically syndrome, okay, that where we don't have any reason, then we call it as epilepsy, okay. It is a syndromic association. Seizure is one-time occurrence, okay. If it occurs more than once, then epilepsy has a different definition. I don't want to jump into that, okay. So importance is syncope. So what is syncope? Syncope means there is just loss of consciousness, nothing else, okay. Just loss of consciousness is called syncope. But there's one variant of seizure which mimics like syncope, and that is atonic seizure. Atonic seizure is where suddenly patient have loss of tone only, like patient will just collapse, there won't be any active movements and all, okay. So one of the differential diagnosis of syncope is atonic seizure, not other type of seizures. Second is there are many other things also that can cause seizures, like hyponatremia can cause seizure, hypernatremia can cause seizure, hypocalcemia can cause seizure, hypomagnesemia can cause seizures. Similarly, hypoglycemia can cause seizures. Okay, even heat pyrexia. Okay, pyrexia, that is hyperthermia, that also can cause seizures. Febrile seizures can cause seizures. So there are n number of reasons for seizures, and out of that, one of the most important in your exam is hypoglycemia. So remember always, whenever a patient has seizure, if he has history of diabetes mellitus or something, he is on oral hypoglycemics or insulin. Also remember, hypoglycemia is a cause of seizures. Next, carbamazepine has no role in absence seizures. Carbamazepine has role only in focal seizures, which was earlier known as partial seizures. There is no role in absence seizures. It will worsen absence seizures. Okay. Yes, I think I have explained everything that is related to epilepsy. Now we'll go to motor neuron diseases. Yes. Next, we'll be going towards motor neuron diseases, and we have few motor neuron diseases which you should know. Okay, for exam point of view only. So first one is this ALS, which we had extensively discussed. Okay. Then we have four more types, that is PBP, which is basically progressive bulbar palsy. PMA is progressive muscular atrophy. PLS is progressive lateral sclerosis, and SMA is spinomuscular atrophy. So only SMA occurs in children, that is in infants and childhood age group. There are different types of SMA. Rest all occurs in adults, and these are degenerative diseases basically. Okay. ALS occurs, which we have already seen, occurs in juvenile like adolescent age group. Okay, after 30 to 50 years, between that age. Now for this, you should know what is upper motor neuron and what is lower motor neuron. And few slides before, I explain that in detail. What is upper motor neuron, what is lower motor neuron. Basically, upper motor neuron is from the cortex till the till the anterior horn cell. Okay, that is corticospinal tract, that is UMN. And anything below, from the spinal cord level, that is anterior horn cell, till your muscle, that is the nerve supplying the muscle. Okay, till there it is lower motor neuron. Okay, so we'll see briefly what are the differences, because in MCQ you should be able to differentiate these. ALS, I told you, there will be upper motor neuron sign also, lower motor neuron sign also. Both are present. No sensory loss, because it only affects motor nerves. Now, what are upper motor neuron signs? Upper motor neuron signs means spasticity. Okay, Babinski positive, hyperreflexia. These are upper motor neuron signs. Lower motor neuron signs are flaccidity. Okay, decreased reflexes. Okay, these are lower motor neuron signs. Now, what happens in progressive bulbar palsy? See, bulbar means brainstem cranial nerve nuclei. Palsy means this one, paralysis. So, it occurs in the bulbar. Bulbar means cranial nerve 9, 10, 11, 12. Okay, these nerves. So, what will be the symptoms? Dysarthria, because these are bulbar symptoms. Bulbar means brainstem cranial nerve nuclei symptoms. Dysphagia. So, this PBP has poor prognosis. You should remember only this much. It is a progressive bulbar type of lower motor neuron palsy, which manifests as dysarthria and dysphagia, occurs in elderly age group, and it has poor prognosis. Similarly, PMA, that is progressive muscular atrophy, it involves degeneration of these anterior horn cells, leading to wasting and fasciculation. This wasting and fasciculation are also LMN symptoms, okay, lower motor neuron symptoms. But this is in the limbs, it is not in the cranial nerve region, okay, it is not in the bulbar region. Next, progressive lateral sclerosis is almost similar to amyotrophic lateral sclerosis, except here we have UMN plus LMN signs. Here we have only UMN sign, that is corticospinal tract. Okay, so there is only spasticity. There is no flaccidity. There is no decreased reflexes. There is no wasting. There is no fasciculation. There is mainly spasticity. And last, we have SMA, which is spinomuscular atrophy, occurs in infants and toddlers and children. So here basically there is SMN1 gene defect, SMN1. What is in depth will go in pediatrics. Okay. So, which is the commonest among all these degenerative motor neuron diseases? Commonest is ALS, which we had discussed separately. And ALS also has upper motor neuron plus lower motor neuron symptoms. Drug of choice for ALS is riluzole. Okay. Now remember, Babinski associated with fasciculations, these are typical of motor neuron disease. Okay. So, Babinski represents UMN, fasciculations represent LMN. SOD1 mutation, this we saw in ALS previously, it occurs in ALS. Okay. Next, cognition is paired in almost all cases of motor neuron disease except ALS, if it is associated with frontotemporal dementia. Okay, otherwise cognition is not impaired. Okay, it is paired. Riluzole and edaravone, these two drugs are known to prolong survival. Again, motor neuron diseases are very degenerative diseases, very dangerous one. Sensory loss won't happen. There is no sensory nerve involvement in motor neuron disease. Name itself suggests it is motor neuron disease. It is not sensory nerve. And you can confuse it with polio because like it can be shown that it is ascending type of paralysis and all. So don't go with polio. I told you again and again, polio is a asymmetric ascending type of paralysis. Okay, remember this much. Next, ventilator support improves survival, and mainly it is multidisciplinary approach. Okay, so I think all these things you can go through. Yes, we'll go to next topic, that is multiple sclerosis. So multiple sclerosis is totally different. This is just like myelin sheath is involved. Okay, so this is similar to DDs of multiple sclerosis are basically GBS. Okay, you have those demyelinating polyneuropathies. Okay, basically it comes under polyneuropathy heading. Okay, broad heading. Okay, so basically what is there? CNS demyelination occurs. That is, this myelin sheath is broken down because of antibody mediated myelin sheath destruction. Okay, as a result of which axon injury occurs, and we have relapsing neurological deficit, which is very important. Relapsing means it occurs again and again. It can relapse again and again. Okay, so which are the important symptoms that you should note for multiple sclerosis? One is optic neuritis, which means optic nerve is involved and it causes painful vision loss. Remember, it is not painless. Painful vision loss is optic neuritis, okay, and that occurs in multiple sclerosis. So painful vision loss is the first manifestation of multiple sclerosis. Next, there is something known as internuclear ophthalmoplegia. It is known as INO. I don't want to go into depth what it is, okay, because this is a revision course. This is not a first time like study course, okay. So basically what happens, there is defect in the adduction of the eyes, okay, adduction, not abduction, adduction defect is there, and this is because of MLF pathway, that is medial longitudinal fasciculus. Okay, so this is an interconnection which I won't go into depth again because it is so much. So adduction defect occurs, that is you can't the work of medial rectus basically is adduction. Okay, so that is compromised. Okay, so this is because of this MLF pathway which has many interconnections in between, so that causes internuclear ophthalmoplegia. Next is important is on MRI you will get this Dawson's finger appearance. Okay, so this you see here, these are Dawson's fingers. Okay, so Dawson's fingers appearance occurs in because of this periventricular plaques in CNS. Okay, that is a MRI finding. Next, when you do CSF, you will find oligoclonal bands. Okay, so you will find this separate bands when you test. Okay, so that is known as oligoclonal bands occurs in multiple sclerosis. And next, relapsing remitting course is characteristic, which means it will go into relapse and then again it will come again. Okay, so this relapsing remitting course is the commonest form of the multiple sclerosis. So there are some important two signs which you should note. One is Uthoff sign and second is Lermit sign, which is typical for multiple sclerosis. Uthoff means in case of heat, okay, which means whenever the patient has hot water bath and all, the symptoms will actually increase. What are the symptoms? Symptoms is like painful vision loss, or there will be UMN symptoms, spasticity, there will be focal neurological deficits. All this will increase when when the person is exposed to heat, okay, warmth. Second is Lermit sign, when patient has a shock-like sensation radiating from the neck. Okay, this is known as Lermit sign. So these two signs are typical of multiple sclerosis. Next, vitamin D supplementation helps. So don't confuse multiple sclerosis with peripheral neuropathy. That is because peripheral neuropathy, in which nerves are involved directly. In multiple sclerosis, antibodies damage myelin sheath and hence we have all these symptoms. Okay, and very important, steroid. Steroids are the mainstay of treatment in multiple sclerosis. So you shouldn't delay steroids. If you delay, then it can be very difficult. Okay, so steroid delaying is not the option in multiple sclerosis. So what is the treatment of choice which will actually prevent relapses? It is IV methylprednisolone, which is nothing but a potent corticosteroid. To prevent further relapses, we can also go for interferon beta, and there is a drug known as glatiramer. Glatiramer is used in multiple sclerosis. Okay, all these I have explained. This also I have explained. This also I have explained. Okay, yes. Next, we'll go to topic that is myasthenia gravis, a very important close differential diagnosis of Lambert-Eaton syndrome. Okay, Lambert-Eaton myasthenia syndrome. We call it as Lambert-Eaton syndrome. Okay, LES. Yes. So what happens is here again it is antibodies. So whatever you see in CNS, half of them is always related to antibodies, whether it will be GBS or multiple sclerosis or myasthenia. There are so many autoimmune things that are occurring in CNS, and one of them is myasthenia gravis. Okay. So here also autoantibodies are there, but these are against where? These are against these nicotinic receptors present in the post synapse. Okay. Basically where acetyl goes and sits, no, acetylcholine, there only there will be antibodies mediated against it. Okay. So as a result of it, this neuromuscular junction becomes useless and patient will go into fatigue. So fatigable weakness. Okay. That is the most important symptom in your MCQs. So what is the earliest manifestation? Yes, earliest manifestation is ptosis and diplopia. So this is diplopia where you'll see 2-3 objects, and this is ptosis. So ptosis along with diplopia, which actually worsens towards evening. Morning patient will be okay. Towards evening there will be ptosis and diplopia. This diurnal variation is typical of myasthenia gravis. Second is there will be generalized. That is it will be involving bulbar also. It can involve limbs also. So, and it fluctuates. So it can be bulbar and limb involvement also. Third is which antibody is involved. Very important. It is anti-acetylcholine receptor antibody, and second is MuSK antibody. Okay, anti-MuSK antibodies. This is the diagnostic marker. Now there is an important link of this myasthenia gravis along with thymoma. So if there is thymoma, this thymoma can actually release some antibodies, and these antibodies can cause myasthenia gravis. Next, eye speck test. When you keep eyes, no, actually symptoms improve. Your ptosis improves. This is a bedside clue for myasthenia gravis. Important things are reflexes are normal. Sensory pathway is also normal. So this is a neuromuscular junction defect. This is not a nerve defect. Next, MuSK antibodies are more predominant in bulbar type of myasthenia gravis. Okay, bulbar variant where there will be associated dysarthria, dysphonia, okay, dysphagia. In that variant, musk antibodies are more common. Okay, so don't confuse it with Lambert-Eaton syndrome. So Lambert-Eaton syndrome is the most common differential diagnosis. Now itself, go back to your respective coaching app platform notes and read what is Lambert-Eaton syndrome. You shouldn't confuse this with myasthenia gravis. So 2-3 important points to differentiate with this myasthenia gravis versus Lambert-Eaton syndrome. I'll just write it down. Okay, myasthenia gravis and Lambert-Eaton syndrome. Okay, so first thing, this myasthenia gravis is against what? Postsynaptic. I told you already, it is postsynaptic. Lambert-Eaton is presynaptic. Okay. Second, in myasthenia gravis, there will be predominantly diplopia. That is, first cranial, that ophthalmoplegia and diplopia will be involved. Not ophthalmoplegia, sorry, ptosis. Okay, ptosis and diplopia. And in Lambert-Eaton syndrome, most commonly it will involve proximal limbs. Okay, it doesn't start with diplopia. Third important point, reflexes in myasthenia gravis are present, reflexes. In Lambert-Eaton syndrome, reflexes will be decreased. Fourth important point, myasthenia gravis is associated with thymoma and Lambert-Eaton is associated with the squamous cell carcinoma of lung, okay? Sorry, it is small cell carcinoma of the lung. And fifth, very, very important point that you should remember is, in myasthenia, when you do exercise, that is, if you, I said no, there is diurnal variation towards evening, there will be fatigue. Fatigue will be more. That is because when you do exercise, the replenishment of acetylcholine is less. So that's why you will get more weakness when you increase with exercise. So with exercise, weakness increases, but in Lambert-Eaton syndrome, it is opposite. With exercise, weakness improves. Okay, weakness improves with exercise, and in myasthenia gravis, weakness increases. That is, your symptoms will increase with exercise, and here its symptoms will improve with exercise. That is, your symptoms will decrease with exercise. Okay, so these are the points to differentiate. And believe me, if neuromuscular junctions question is asked in myasthenia, 100% one option will be Lambert-Eaton syndrome, and you will always make mistake in this question only. Yes. Next, yes, what is the treatment of myasthenia gravis? Simple. You should give something which actually increases acetylcholine. So you should give parasympathomimitic, that is basically pyridostigmine. Okay. Next, prednisolone also improves because there is autoimmune basis for this. No? That's why prednisolone improves. And third is thymectomy. Thymectomy improves because thymoma will be producing these antibodies. Now, what you should avoid? You should avoid magnesium and aminoglycoside because both these decrease transmission across receptor. Okay, that is postsynaptic receptor. So you will decrease both. Okay, you will avoid both. Next, antibody, which is antibody that is involved? Acetylcholine receptor antibody and anti-musk antibodies. Okay. Earliest feature is ocular feature and associated is thymoma. Okay. So I think I have explained everything related to this. Next, we'll go to neurofibromatosis. Next topic is neurofibromatosis, and we are concerned more about neurofibromatosis type 1. Okay. So chromosome number is 17. Now the classic way to remember is neurofibromatosis has total 17 alphabets. That's how you remember it. And neurofibromatosis 2 for 22. Okay, so that's how we remember neurofibromatosis 2 chromosome number. So this chromosome 17, there will be mutation in NF1 gene causing decreased neurofibrin, which is basically involved in RAS pathway, which controls protein and cell proliferation. So cell proliferation will increase, as a result of which they have more tendency towards malignancies such as tumor formation, such as neurofibroma, and then you have café-au-lait spot, all those. Okay, optic gliomas. So what are the criteria? These criteria are essential for your exam. One is café-au-lait spots. Now how many? So it should be more than 5 mm, first criteria, and if in a child it should be more than 5 mm, in adult it should be more than 15 mm. Okay, that is diagnostic. And how many should be there? Total 6 or more. So 1 or 2 café-au-lait spot has no meaning. So it should be more than 5 mm and more than 15 mm in adults. Second is this Croson, also known as axillary freckling, which should be there. Third is neurofibroma. If it's a neurofibroma, then it should be more than 2. And if it is a plexiform type of neurofibroma, it should be more, at least 1 is also sufficient. Fourth is optic glioma association, which will be seen on MRI. And then you have Lisch nodules, and then you have learning disabilities which are seen. Okay, so basically tumor which is seen is optic glioma, eye lesion is Lisch nodule, axillary freckling is present. In neurofibromatosis type 2, you will get bilateral schwannomas. Okay, so NF1 is mainly limited to skin and bone, and NF2 is basically bilateral acoustic neuroma. Okay, so don't confuse both of them. And if there is only one café-au-lait spot, that doesn't mean it is neurofibromatosis. So what do you need? You need to monitor vision. Why? Because of risk of developing optic glioma. Okay, so because optic glioma presses on the optic stalk and this one optic nerves, hence vision problems can come. And second is you have to monitor for hypertension. And avoid trauma to these lesions, basically to neurofibromas. Okay, so these are the basic things that you need to know. Most of the questions will be on this café-au-lait spots only and chromosome number. Next is neurofibromatosis type 2, where here the hallmark is basically the bilateral acoustic schwannoma, and this will be your MCQ indicator. Bilateral acoustic schwannomas, that is cranial nerve 8th schwannomas. Okay, so these are basically seen in neurofibromatosis type 2. Here the protein is known as Merlin protein, which is seen in chromosome 22, as I told you. And next, it can also cause intracranial meningioma. This is the diagram of it, which you see on MRI. And you'll see spinal ependymoma. And along with this, one peculiar feature in eye, where Lisch nodule was for neurofibromatosis neurofibromatosis 1. Here it is posterior subcapsular cataract. Okay. One more thing, posterior subcapsular cataract can also be seen with steroid abuse. One more is in neurofibromatosis type 2. Okay. And we'll have audiometry hearing loss, that is because of involvement of this acoustic schwannomas. Okay. So I think all these things I have explained. So here also treatment is surgery and radiotherapy. Rest everything I have explained. Okay. Next, we'll go to Parkinson disease, which we had extensively discussed in pathology also. So what happens is there is normal substantia nigra, which is pigmented, which carries dopaminergic neurons. So here there is a dopaminergic neuron loss, and hence there is depigmented substantia nigra, leading to decreased dopamine and all these features, that is pill rolling tremors, lead wheel or cogwheel rigidity, and bradykinesia. All these things occur because of decreased dopamine neurons. So rest, all these things I have explained. And falls, no, that is actually a late feature of Parkinson. Initially there won't be postural instability. Later on there will be, earliest will be the tremors during rest, that is pill rolling tremors. Okay. Next, Lewy bodies are characteristic pathological finding which consists of alpha-synuclein. Also remember that this alpha-synuclein Lewy bodies are also seen in Lewy body dementia. Okay. There also it is seen. Next, basal ganglia involvement causes imbalance, and then there is dopamine depletion in Parkinsonism. Earliest sign is the resting tremors. Okay. Then bradykinesia, slow movement, and there will be drastic response to levodopa. There will be a lot of improvement. Now, very rare facts are that depression is associated with Parkinson disease. That can also be asked. And anosmia is one of the earliest indicator. Okay. So anosmia precedes even resting tremors. Okay. Next, what is why I'm focusing on resting tremor is because there is something known as intentional tremor, which means when a person goes to hold an object, when there is intention to hold an object, that time tremors occur. That is known as intention tremors. Here it is resting tremors. Okay. Next, levodopa carbidopa is the treatment of choice along with MAO-B inhibitors or dopamine agonist. Other treatment include deep brain stimulation, which is used in advanced cases. So always remember levodopa plus carbidopa is what we give. Okay. And along with that, as synergistic action, we'll give dopaminergic agonist and MAO-B inhibitors. Okay. Now, why MAO-B inhibitors? We have seen in pathology that pharmacology that they prevent catabolism of dopamine. Okay. Yes, I think I have explained all of this. Yes. We'll next go to next topic, that is polio. So, so far in medicine, I have already told you that poliomyelitis is a type of ascending type of asymmetric paralysis. Okay, ascending asymmetric paralysis. I have already told this many times. In contrast to botulism and diphtheria, which have descending paralysis, polio and GBS have ascending paralysis. Okay, so what is the mechanism of action? How does polio cause all these symptoms? So polio is basically an enterovirus which enters through fecal-oral route. It goes to the intestine, then it travels to the CNS, that is the spine, and it goes to anterior horn cells. So there it causes lower motor neuron type of damage, resulting in asymmetric flaccid paralysis, that is lower motor neuron involvement with normal sensory nerve or without any sensory loss. So there is no sensory nerve involvement. It is a pure motor type of disease. So first it is enterovirus. Second is lesion is in the anterior horn cell. Third is reflexes are absent because this is an element type of lesion. Fourth is sensory is normal, and sixth is vaccine prevents. Actually, we have both injectable and oral polio vaccines. Now there is something called as post polio syndrome, which you should be knowing about. And second is CNS lesion. There is only motor deficit. There is nothing else. So your most common differential diagnosis is GBS, because GBS is also ascending paralysis, but GBS is symmetric. Remember this, symmetric. Okay. Yes. Next, what is the site? Anterior horn cells. Next, vaccines I have already told you. Weakness I have told you. Flaccid paralysis, GBS, how to differentiate also I have told you. Okay. Supportive care, there is no role of any antivirals. Okay, and you avoid live OPV in immunodeficiency because OPV has actually immunogenicity. So it can cause pathogenicity. That is, if your person is immunocompromised, then it can actually cause polio in them. That's why we avoid live polio, and it is true for any live vaccine. Okay. Yes, so I think I have explained everything. We can go to the next topic. Main thing is differentiating it from GBS. So next topic is generalized topic, that is pseudotumor cerebri, which is basically nothing but idiopathic intracranial hypertension. Means there is raised intracranial pressure, but we don't know why raised intracranial pressure is raised. Okay. Yes. So basically what happens is there is decreased CSF absorption from the meningeal layers and this dural venous sinuses, as a result of which ICP increases. Ventricles are normal. Actually in hydrocephalus, that is raised ICP, or when there is increased like CSF retention, ventricles should enlarge, but here ventricles are normal. But there is presence of optic nerve swelling. Okay. Whenever there is increased ICP, remember, no, there is papilledema. Papilledema means there is optic disc swelling. Okay, papilledema. This optic disc swelling is present in intracranial hypertension, but we don't have any apparent cause of intracranial hypertension. So we have papilledema along with headache. This is the commonest feature. So how does this occur? This is commonly seen in obese young female, young adult female. Okay, obese female, and where you will see LP pressure, opening pressure is more than 25 centimeter water, which is actually above. Okay, so that's why we call it raised intracranial pressure. And then there is visual disturbances. there is transient obscurations in the image, that is transient blinding. And on imaging, everything is normal. Okay. So basically, what determines is the cause, that is the context of the disease, along with that increased pressures, and then you have papilla edema. Okay, these three are very characteristic. So what are the causative agents? One is vitamin A, carotenoids. So second is retinol and carotenoids. Second is tetracyclines and OCPs. These three are known to cause. So now we want to decrease intracranial tension. That's why we use acetazolamide. We also go for weight loss because obesity is known to trigger it. And third is we'll go for surgery if there is any vision loss that is going to happen. Okay. So yes, remember these things. That is, one is LP, increased pressure is seen, but CSF picture is normal. Drug causes tetracycline, vitamin A and OCPs. Treatment is acetazolamide, and CT is normal, but LP pressure is increased. Okay. Yes. Next, we'll go to rabies. So in rabies, basically it's a virus. It's a Lissa virus. It belongs to RNA virus group, Lissa virus. This is present in the saliva of the wild animals, especially dog. It can also occur via cat or bat also. Virus enters and then it spreads retrograde through the nerve endings, that is from the distal to the proximal end of the nerve. And then it can result in brainstem encephalitis, and then this symptom, that is hydrophobia, aerophobia, fear of air and fear of water, and it leads to spasms and death. Okay. So transmission is via bat. Pathology, you will find Negri bodies. I think everyone knows it, so I don't have to go ahead. So prevention, we use vaccine, okay, rabies vaccine and rabies immunoglobulin. It's a bullet-shaped virus. This can be asked in micro, okay, and Negri bodies are present in Purkinje and hippocampus. So everyone will tell Negri bodies are present, but if the question is where Negri bodies are present, they are predominantly seen in hippocampus and Purkinje. And remember, Negri bodies are diagnostic after brain biopsy. It's not on simple like CSF study or something like that. Okay, it's in brain biopsy. So usually it's always done post-mortem. Okay, post-mortem it is done. Yes. So incubation period is 20 to 90 days. So that's why we watch for like around 10 days earlier, which we used to follow. Now we don't follow it. We watch the rabid animal for 10 days, whether symptoms are there or not. And it is retrograde axonal spread. So virus spread through the nerves. It doesn't spread through blood. Okay. Next. Yes. For cat bites also, you will have to take rabies immunoglobulin or rabies vaccine, depending on the circumstance, category of the wound. And polio can also mimic like rabies, but in rabies you have other symptoms. But sometimes there is something known as flaccid rabies, okay, where actually 20% of the patients will actually go into paralysis kind of state. That can be confused with polio. So I think I have explained everything. This is also explained. So what is the clinical management? First is washing wound 15 minutes with soap and water. Then rabies vaccine along with rabies immunoglobulin. So rabies vaccine will follow on 0, 3, 7, 28. Okay, this is the SN regimen that we follow. Okay, don't forget this. Okay, then there is one more modified Thai regimen which we don't follow now. We follow SN regimen. Okay, there shouldn't be any doubt regarding it. Rabies immunoglobulin is indicated when it is category 2 or category 3 type of wound. Yes, I have explained everything. So let's move on to next topic, that is sciatica. Commonly asked question in orthopedics. Moving on to sciatica. So basically what happens is there is some problem at the disc level, vertebral disc, as a result of which there will be root compression. Basically the root compression is at lumbar 4 and 5 and sacral 1, okay, and then there will be radiating pain towards the leg because of sciatic nerve compression. So first is disc herniation, commonly these levels, okay, then pain gets radiated through this part, okay, and one test which actually differentiates is the straight leg raising test. When the leg is raised like this straight, there will be pain at less than 70 degree. This is 70 degree, okay, at less than that only there will be pain. That is a diagnostic clue, okay. Next there will be reflex loss because this sciatic nerve, this L4, L5, S1, no, these are the control centers for knee and ankle jerk, okay. So depending on where the root lesion is, you can have loss of these reflexes, and MRI of lumbosacral spine is a gold standard. So commonest is root is L5, S1 between lumbar 5 and S1. Radiculopathy, straight leg raising test is positive. Ankle reflex is lost if it is S1 because ankle reflex it is L5, S1, and for knee it is L3, L4, okay. Yes. Next, back pain radiating below knee, it is true sciatica, okay, and then there can be central herniation plus cauda equina. That is, if cauda equina syndrome also occurs along with this spinal cord herniation, then it is an emergency, okay. Next, one of the most common differential diagnosis is this piriformis syndrome, where basically this, because of this inflammation of the piriformis muscle, okay, there will be trapping of this nerve, okay, and that actually can resemble sciatica, okay. So this is one thing which you should be aware in your questions. And second is this L5 root. There can be, if L5 root is involved, there can be weakness in the toe extension. Okay, so this is a important clue towards involvement of L5 root because extension of toe extension is based on this L5 root. Okay, next. There can be some other symptoms associated. For example, red flag signs such as bladder, saddle anesthesia. So if you have bladder and saddle anesthesia, basically it is pointing towards this cauda equina. Okay, so there is compression of the spinal cord lower part, cauda equina, and then it can lead to devastating side effects. It can also lead to paralysis. So hence, if there is bladder or saddle anesthesia, you should always think of cauda equina. Second is for sciatica, early mobilization is very important. Prolonged bed rest is not the treatment that is given in sciatica. Okay. Next, what is the treatment, clinical management? NSAIDs along with physiotherapy, along with the core strength, that is we are focusing towards the core muscles. Okay. And second is surgery if there is any deficit or there is any incontinence. Okay. So that time we'll go for surgical approach. Okay. Yes. So this is a disc bulge that you see, nerve root compression, and then you have this pain along the sciatic pathway, that is nerve pathway. Okay. Yes. L5 is lift, that is toe extension is affected. Next, we'll have a brief session on spinal cord syndromes, and out of this, the most important is this Brown-Sequard syndrome. Okay. So we'll go through all of them step by step. So there will be motor and sensory pattern with, when it comes to spinal cord syndrome based on the level of the lesion. Okay. So first we'll see if half of the spinal cord is involved, what will happen? This half of the spinal cord carries opposite side motor fibers, that is opposite side motor fibers, okay, which are actually descending like this. Okay, so this side contains opposite sides motor fibers which are crossing over. Okay, not here, sorry, it will cross here and then it will come. Okay, so ipsilateral there will be, yes, so these fibers, actually let's take a representation. So this is right side of the brain. Just a second. Yes, this is the right side of the brain and this is the left side of the brain. Okay, so now the left-sided fibers, okay, left-sided fibers, that is corticospinal tract, they'll come to the medulla, then there is pyramid, decussation occurs and it will go to the right side. Okay, and then it will supply right side fibers. So whenever there is a lesion in the right side, okay, so there is actually ipsilateral, that is same side loss of weakness. Okay, there is same side weakness. And along with this, proprioception pathway, that is sensory pathway which controls proprioception, actually ascends on the same direction, in the same direction. Then it goes above, then it decussates above. So that's the same side loss of temperature, proprioception, okay, that is fine touch and proprioception, and same side loss of weakness, okay, that is weakness occurs on the same side. Whereas this spinothalamic tract that carries pain and temperature will decussate to the opposite side and then it will ascend. So hence there will be contralateral loss of pain and temperature. Okay, this is what you need to remember in Brown-Sequard syndrome. Second is anterior cord syndrome, which most commonly occurs when there is a thrombosis or some injury to the anterior spinal artery. So here what happens is, this is the place where corticospinal tracts pass from. Okay, there are two corticospinal tracts. One is anterior corticospinal tract, one more is lateral corticospinal tract. Okay, so when this anterior corticospinal tracts are involved, there will be bilateral motor loss because both sides are involved in anterior spinal artery involvement, and there will be loss of pain and temperature below the lesions, pushing like sparing the posterior column. So posterior column pathway, that is for proprioception, is intact, but pain and temperature actually gets involved with this. Okay. Next, when the posterior cord is involved, basically occurs in tabes dorsalis as in syphilis. What happens? There is posterior cord involvement and hence there is bilateral loss of proprioception and vibration. Okay. Next, in central cord, that is in syringomyelia, what happens is there is cape-like. See, you are seeing the distribution here. No, there is cape-like distribution of loss of pain and temperature. Okay, and upper limb motor weakness is more than lower limb. And in last, that is conus medullaris, conus and cauda equina syndrome. What will happen is there is symmetric versus asymmetric bladder loss. Okay, so this we saw in the previous slide also. So basically, you have 5 patterns of spinal cord injuries that you should remember. One is ipsilateral, same side weakness along with same side loss of proprioception along with contralateral loss of pain and temperature occurs in Brown-Sequard syndrome. Very good. Next, bilateral motor loss. Okay, motor loss along with pain loss, but proprioception is intact. That occurs in anterior spinal cord syndrome. Next, posterior spinal cord syndrome or tabes dorsalis, what happens? Proprioception is lost. Central cord, what happens? Yes, there is cape-like distribution, C for C. Okay. Then in cauda equina syndrome, what happens? There is a bladder loss also along with the distal nerve deficits also. Okay, distal lower limb. So tabes dorsalis occurs in syphilis because of involvement of the posterior spinal cord. Anterior spinal cord is mainly because of vascular causes. So mainly in these syndromes you have only rehabilitation and neurogenic care. Okay, that is bladder care. So I think I have explained everything. Yes, hemisection, Brown-Sequard syndrome. Pain plus temperature loss occurs when the spinothalamic tract is affected. Posterior column pathway results in vibration loss and proprioception loss. Next, upper limb more than lower limb weakness is seen in the central cord syndrome, that is syringomyelia, and crossed pattern, that is one more example. So what is this knife injury and crossed pattern? So basically this occurs when there is knife injury to the spinal cord causing this half of the spinal cord is gone. Crossed pattern means it is basically on one side motor loss is there, along with that proprioception loss is there. On the other side we have pain and temperature loss. So that pattern is known as crossed pattern. Okay. There is one more thing called as crossed hemiplegia. That is entirely different. Okay, crossed hemiplegia is entirely different. So crossed hemiplegia means it is seen in stroke. Okay, in brainstem strokes. So normally what happens is if stroke, that is vascular lesion, is at the internal capsule, Then what happens is there is contralateral hemiplegia, okay, with ipsilateral 7th cranial nerve palsy, okay. But facial deviation is towards the contralateral side. We know that, okay, we discussed this. But what happens in cross hemiplegia? Facial deviation is to the same side, ipsilateral facial deviation, along with contralateral hemiplegia. This happens because this vascular lesion, because of stroke, this happens in the area where decussation happens at the level of pyramid. That time you will get this, okay. Next we are going for subarachnoid hemorrhage. Maybe the image is a little bit different in your PDF. Yeah, so basically there is Barré aneurysm rupture causing worst headache, that is known as thunderclap headache, okay, along with meningeal signs. So most commonly it involves anterior circulation more than posterior communicating artery, okay. And next it is these two MCQ pointers. Investigation of choice is CT head, where you will see star of death, okay. So basically you will see a star pattern at the base that is near the circle of Willis. So when you do LP, basically you can't do LP because raised ICP will be there and it can lead to herniation. But when you do LP after 12 hours, you will find xanthochromia. Xanthochromia is basically yellowish type of CSF, that is because of bleeding. So vasospasm is actually a complication of subarachnoid hemorrhage because of irritation of meningeal vessels secondary to bleed. And for this, what is the treatment? It is nimodipine. Okay, so nimodipine is a treatment for vasospasm that occurs secondary to subarachnoid hemorrhage. So before doing CT, do LP, very important. And second is you might miss hyponatremia also, because secondary to this increased intracranial pressure and this irritation, there will be increased release of ADH. Okay, this ADH, increased ADH can cause SIADH, which can in turn cause hyponatremia. Okay, this you'll have to remember. Next, yes, most common site is anterior communicating artery. Second, the drug which we use to prevent vasospasm as a complication of SAH is nimodipine. Before doing CT, before doing LP, do CT. If CT is negative, only then go for LP. Sudden headache along with stiff neck, that is meningeal signs, you should think of subarachnoid hemorrhage, and xanthochromia actually confirms thing. Okay. Yes, next we have subdural hematoma. So basically between the, there are different layers of meninges, okay. So you have dura mater, you have arachnoid mater, then you have pia mater, okay. So between this dura mater, okay, subdural, that is below the dura mater, okay. Anything that occurs outside this dura mater is called extradural hemorrhage. Anything that occurs between this is known as, between pia mater and dura mater is known as subdural hemorrhage, okay. So we have subdural hemorrhage that is occurring, and below this arachnoid mater you will have subarachnoid hemorrhage. Okay, so we have total 3 layers. Okay, so first is dura. So here we have extradural hematoma. Below dura we have subdural hematoma, and below this arachnoid and pia mater, there we have subarachnoid hematoma. Okay, there shouldn't be any confusion regarding this. So what happens is there are bridging veins. These are the bridging veins. Okay, these veins will rupture and they'll bleed into this subdural space. That is the reason for this subdural hematoma, and you'll get this crescentric. Okay, crescentric shape you'll find. And in extradural hematoma, you will find actually concave lens shaped hemorrhage. Okay, concave lens shape is for extradural hemorrhage, and this boat shaped, banana shaped is for crescentric is for subdural hemorrhage. It occurs in elderly and in alcoholic, and there will be gradual loss of consciousness and there will be headache. So this is less dangerous compared to subarachnoid hemorrhage. There is something known as chronic subdural hemorrhage, and this occurs mainly in trauma in case of shaken baby syndrome. Okay, so when babies are shaken vigorously because of abuse, parental abuse, or some other traumatic experience, what happens is these bridging veins they'll rupture and they'll cause chronic subdural hemorrhage. Okay, so you will find midline shift in case of subdural hemorrhage because brain matter is compressed towards the other side. Yes. Okay. Next. There is a problem with subdural hemorrhage, that is it can recur even after drainage. So you open the skull, you drain the hemorrhage, but then it can also recur. Okay, and it crosses suture because there is no it crosses suture lines. Okay, it doesn't cross the Fax lines. Fax are basically the dural coverings. Okay, it doesn't cross that, but it crosses the suture lines. Next, lentiform is actually what we see in case of extradural hemorrhage. Here we see banana shaped. Okay. Next, what is the treatment? If acutely symptomatic, we do burr hole drainage. That is, we do a burr hole in the skull, and then we release intracranial pressure, and that is for acute management. Okay, acute symptomatic management. I think I have explained everything here. Yes. We'll go to the next topic, that is syringomelia. So what happens in syringomelia is there is basically this fluid-filled cavity within the central spinal cord. That is, in the spinal cord there will be a canal that gets enlarged. Okay, so this cystic cavitation or syrinx formation. So this is known as syringomelia, and it will damage the anterior commissure of the spinal cord. So because of this, we saw in 2 slides before that there will be cape-like loss. Cape means along this area, okay, along the shoulder and upper limb area, there will be cape-like loss of pain and temperature. Okay, touch is normal, but pain and temperature is affected because anterior spinal thalamic tract, which actually carries fibers of pain and temperature. They pass along this commissure. Okay, so most commonly it involves a central canal in the C8 to T1 area, and that's why we'll have mixed LMN and UMN signs. And there can be one associated feature, that is Chiari-1 malformation. So Chiari-1 malformation is nothing but ballooning of the cisterns around around the brainstem. What are cisterns? Cisterns are CSF filled spaces. Okay, that much only you remember. So yes, Chiari, you might have heard of Arnold-Chiari syndrome. There are type 1 and type 2. In type 1 is associated with this syringomyelia. Okay. Second is this because of this involvement of spinothalamic tract, you will have dissociated sensory loss, and in children it can also lead to scoliosis because of this C8 to T1 involvement. Okay, these are the superficial things that you need to remember. Okay, I won't go much in detail with this because not much is required. Just remember that there is syrinx dilatation, that is canal formation between C8 to T1. Okay, spinothalamic tract is damaged. There is cape-like loss of pain and temperature. Okay, and then there is weakness in the hands. Okay, that is because of lower motor neuron that accompanies. Okay, and there will be UMN signs in the legs. Why that occurs, all the details are not required. Okay. Moving ahead with the next topic, that is tension headache. So initially we saw cluster headache, then we saw migraine, and now we are going towards tension headache. So this is a benign type of headache. So what is the MCQ indicator that is there? The thing is bilateral band-like pressure, okay, without any warning signs, without any aura, nothing, no vomiting, no photophobia. So bilateral band-like sensation, which increases towards the end of the day. So dull band-like associated with stress, fatigue, and sleep loss. No associated symptoms. It will last for 30 minutes to up to 7 days sometimes, and relief is with NSAIDs with relaxation, and this is the most common type of primary headache. Okay, so these are the red flag signs which are not there in this. For example, no throbbing, no aura, no muscle tenderness on scalp. No other features of migraine. Okay, so this lifestyle modification, actually proper sleep, proper food, stress relieval, all this actually improves. Okay, if it is chronic type, then we give amitriptyline. Okay, otherwise we don't give anything. Okay, we just give NSAIDs. So I have explained everything. So yes, first line treatment is NSAIDs. Okay, so there shouldn't be anything else. Yes, it is present every day, which is very common. Okay, at the same time, especially at the evening, it is tight band-like sensation, not accompanied by nausea. Stress trigger will be there. Involves a scalp tenderness. Okay, so scalp tenderness will be there, and over-the-counter NSAIDs will be there. Will be the drug of choice. Okay, so no aura. So it's a simple thing. We shouldn't miss on MCQs. Next is tetanus. So tetanus we'll also see in the microbiology. So in tetanus there will be bacterial entry, that is tetanus spores will enter through wound entry, and then there will be release of this toxin known as tetanospasmin. So there will be two toxins in this. One is A part and B part. Okay, these inhibit GABA. Okay, GABA, and hence it leads to blockage of inhibitory signals, blockage of glycine and GABA, and hence we get spastic paralysis. Basically there will be spasm and then followed by paralysis of the limbs. Okay, so toxin is tetanospasmin. Okay, what is the first symptom of tetanus? That is nothing but lockjaw, that is trismus. Okay, you can see here image. Next, rhizus sardinicus is a smile that happens because of spasm of the facial muscles. Reflexes are exaggerated because you don't have any inhibitory impulses. Backward spasm is known as opisthotonus, arching of the back. Prevention is using toxoid vaccine and tetanus immunoglobulin. Okay, so important thing is there is no sensory loss. Neonatal form of tetanus can occur when there is infection of the umbilical cord. That is in previous previous generations, cow dung was used for treating umbilical cord. Okay, cow dung was applied on umbilical cord, and there's tetanus spores will be there. So that was a common way of contamination. Then muscle relaxants are used in case of severe spasms. Okay, in severe spasm we actually sedate the patient. We induce a muscle relaxation, because or else there will be lot of spasm. Okay, now using muscle relaxants alone is of no use. So along with muscle relaxants, we'll be using sedative agents also. Okay. Yes, next, anytime there is a dirty wound, that is category 3 wound, contaminated wound, and patient has not received any tetanus priorly, so we'll give tetanus immunoglobulin also in that case. Okay, so important is sedation. Then along with that, metronidazole is given because tetanus spores for tetanus bacteria, okay, direct killing action, and we should maintain airway support because we are giving sedation. So which is the neurotoxin? Tetanospasmin. Which neurotransmitter is blocked? Glycine and GABA. Prophylaxis is via TIG and toxoid, tetanus toxoid. Okay, first symptom is lockjaw, and flaccid paralysis doesn't occur, it is spastic paralysis. Okay, flaccid occurs in botulism. Okay, so I have covered everything. So next we'll go to transient ischemic attack, which is a part of stroke. So if it lasts for, if neurological deficit like hemiplegia or some hemiparesis lasts for less than 24 hours without any residual this one, okay, that is, it is completely reversible, and MRI is also normal. So in that case we call it as TIA, which means it's a warning for stroke. Which means this time the blood flow was restored, hence there was no any deficit. Okay, but in future it can directly lead to stroke. Okay, so temporary arm weakness or temporary limb weakness, all those comes under TIA, which gets reversible. So usually it is less than 1 hour duration within which it gets reversed. So it could be because of embolic or it can be because of thrombotic. there is transient ischemia, after which circulation is restored. So there is no infarct. Most common source is carotid stenosis. Remember, carotid stenosis is the most common source for transient ischemic attack. Now, how do you calculate high stroke risk? That is using ABCD2 score. Now, what is ABCD? It's given over here. A is for age, B is for BP, that is hypertension or not, C is for clinical features, D is for duration, and other D is for diabetes. Okay, so this is ABCD2 scoring. You should know the full form at least. Okay, next, immediate treatment is using antiplatelet therapy, and then you control risk factors. Okay, so recurrence is if stroke occurs within 48 hours. So recurrence means stroke, again TIA occurs within 48 hours, and this has very high propensity towards going to thrombotic stroke. Okay. Next, hypoglycemia is not TIA. Hypoglycemia also can occur with similar symptoms. It is not TIA. Okay, so you should start antiplatelet immediately along with statin, dual antiplatelet. That is, you go for aspirin, okay, along with clopidogrel, and then you give atorvastatin. Okay, this is the combination. Now, ABCD2 score more than 4 is a criteria for admission. So how do we score it? First is age. If age is more than 60 years, age is more than 60 years, I'll just write it down. Age is more than 60 years. BP is more than 140/90. Clinical features, that is hemiplegia and speech disturbance. Duration is for more than 60 minutes, and presence of diabetes. Okay, so you score this along with this. Okay, so total, so clinical features, you have two categories. One is weakness, and second is speech disturbance, and diabetes, and duration more than 60 minutes or less than 60 minutes, and diabetes, whether it is present or not. Okay, so total score is 7. If it is more than 7, more than 6, okay, more than 6, that is 6 to 7, that means there is high risk for developing stroke. Okay, so it basically predicts 2-day stroke risk. Okay, in next 2 days, what is the stroke risk? That is what it predicts. Okay, yes, I think I have covered everything. Yes, everything is covered. Next, we'll go to trigeminal neuralgia, the last topic of neurology. So in trigeminal neuralgia, what happens is there is involvement of this trigeminal nerve. Okay, so sudden electric shock like facial pain, which is triggered by touch due to compression of this trigeminal nerve. Okay, so here you have trigeminal nerve which is passing, and there will be some trigger for that. Like for example, there is this superior cerebellar artery which actually is positioned near this trigeminal nerve, because of which there is a triggering factor of this trigeminal nerve. Whenever it stimulates, there will be sudden shock-like sensation over the face, and this is a very painful condition actually. Okay, so suddenly patient will get so much excruciating pain, and if left untreated, many patients even think of ending their life. It is that severe disease. Okay, trigeminal neuralgia. So nerve branches which are involved is V2, that is maxillary division is more involved than mandibular than ophthalmic. Okay, so V2, that is maxillary division, is more involved. So pain type is, it lasts for only seconds to minutes. So it is severe stabbing type of pain. Okay, what is the trigger zones? Cheek, lips, chin, that is maxillary area is a trigger zone. It is caused by compression of this superior cerebellar artery. Okay, that loop is there. Okay, that will actually trigger this nerve. And what is that first line treatment? That is carbamazepine. In recession cases, we go for surgical management also. So it may occur in correlation with MS, that is if bilateral it is there, then it can be because of multiple sclerosis. Females are more commonly affected than males. Okay, so it is not a constant aching type of pain, it is a sudden paroxysmal pain. Okay, so if in your MCQ there is constant aching type of pain, then that is not trigeminal neuralgia. And missing SCA compression, superior cerebellar artery compression on MRI is actually which you shouldn't do. So most affected branch is V2, maxillary part of the trigeminal nerve. First line drug is carbamazepine, and associated disease. Yes, so associated disease is multiple sclerosis. Okay, so think of all this. Also remember, which is that shock-like sensation you get over the neck and over the limbs, upper limbs, when in which disease do you get? Yes, it is in multiple sclerosis. What is it called? Yes, very good. It is called as a Lermit sign. Yes, Lermit sign. And what is Uthoff sign in multiple sclerosis? Yes, Uthoff sign is nothing but when you are exposed to heat, that time symptoms will aggravate. So if this trigeminal neuralgia is not responsive to medical treatment, then you go for microvascular decompression or radiorhizotomy. Okay, so basically you free the nerve endings. Okay, nerve roots. Okay, so mainly the pain is because of this compression of trigeminal nerve. Okay, now very important, this trigeminal nerve is important from clinical point of view also, because these patients will always be very distressed, because they won't be even able to sleep because thinking of this pain, like it will be sudden stabbing type of pain. No? They even think of ending their life because of this pain. Okay, so there have been many instances where actually a patient has come to a doctor. I read an article where actually a patient came to an ENT surgeon telling that I have brought poison bottle with me. If you don't treat this immediately, if you tell that there is no hope, there is no treatment for this, I'll just drink it and end my life. So this is that sort of what you say, dangerous diseases, like depressing diseases, painful diseases that mankind has ever known. Okay, so with this we cover neurology. So I have covered almost every important topic. One important topic which I wanted to focus is brainstem syndromes, named syndromes. Okay, you can selectively go through the tables in your MCQ banks or through the pearls, or you can go through your notes selectively where you can read about this brainstem syndromes. Okay, so that part I have particularly not included because it becomes very confusing later on. I have included everything that is required under medicine. Okay, so we'll next go to GIT part and hepatology, so gastroenterology and hepatology. So hopefully you have liked this session. If you want to revise these things, you can purchase the PDF which is available in the comment section. In the pinned comments you'll get link for the PDF. Okay, next we'll go to GIT.